Grace Katie Bell is a nurse consultant with Well Indian Health MAT project. They offer technical assistance, mentoring, and training for California Indian health clinics as they develop their MAT programs. Ms. Bell has co-facilitated in the UCLA Hub and Spoke Learning Collaborative and is a monthly participant for UCLA's Tribal Project ECHO for Indian health primary care clinics throughout California. Katie is currently a nurse case manager for the medication-assisted treatment program at Chapa Day Indian Health in Grass Valley, California. She's board certified in addictions RN. Katie has been working with the medication buprenorphine, naloxone, Suboxone since 2001. She's phase 3 NIDA clinical during the phase 3 NIDA clinical trial. Having developed programs for OUD and other substance use disorders in multiple settings, including Department of Veteran Affairs, the Betty Ford Center, a methadone clinic, and now primary care. She brings an understanding of patient care and advocacy in a variety of healthcare settings and systems.
I want to talk about stigma a little bit. We have identified it as the #1 barrier, and sometimes it's just kind of a vague, broad term. What does that mean? And I have been working as a nurse in addictions for almost 20 years, and I have really seen the impact of it on individual people. And I've been really interested. I've talked a lot with my patients over the years. And, last week I had somebody who really needed to go to the ER, and it was like, I won't go. I just won't go because of the stigma. So, new slide. Okay, so new slide again. Here's our learning objectives. Let's see how that goes. I'm also handing out an anonymous stigma surveys. Everybody have one? Very interesting. So this survey is to be taken anonymously. I'm not going to collect it. It has some very interesting questions about how we think about people with addiction. So I encourage you to take that. Next slide. Only 1 in 10 people with substance use disorder receive treatment. So this is maybe a slightly older ratio, but it really speaks to what has been happening in the last 20 years. This opioid epidemic just kept going. And so our patients who have survived this have spiraled down. The whole addiction process is one of things getting worse, never better. The using continues. So I've noticed that my patients who 5 years ago might have still had a home are now homeless, may have had a job or had a family. Those things have, those consequences have happened in a really big way in our community. So it's time for us to really hustle in terms of addressing this. Next slide. So stigma assumes many forms. It appears as prejudice, discrimination, fear, shame, distrust, and stereotyping. Next slide. It is shaped by our thinking, a bias and a perception that substance users are bad or immoral rather than ill with a chronic condition. Often this is tied with other chronic conditions, such as a co-occurring mental illness. So it really can be a compounded stigmatizing of people. It's communicated through tone, through interpersonal attitude. Do we pull away or do we lean in? Body language is a really big part. How their microaggressions is the word we use. Stigma is communicated by words, and stigma becomes internalized by the person seeking help. The person views themselves as bad, as dirty, as weak, which fuels the shame and stigma. Next slide. So this is a quick guide to our acronyms and terms. MAT means medication-assisted treatment. Some agencies are now using medications for opiate use disorder. Opiate use disorder is OUD. Stigma is what we're talking about, the barrier to care, communicated by language and judgmental attitude. Diversion is a term we use when we talk about any time medication is prescribed and it is traded, sold, bartered, shared. That's a form of diversion. The other is the diversion of illicit drugs. And misuse replaces the word abuse. Taking more than prescribed, using non-prescribed opioids, including IV heroin. Misuse. Next slide. Stigma contributes to the slow, underfunded response to the opioid epidemic. In other words, it's all about money. Right now, the money is coming. There's a fire hose of money coming at us to treat this, but let me tell you, it has been long and slow. We must help everyone see that addiction is not a character flaw, it's a chronic illness that we must approach with the same skill and compassion with which we approach heart disease, diabetes, and cancer. Addiction is a chronic, progressive, relapsing disease. Next slide. Stigma is pervasive and pernicious, found within the walls of care. Within the walls of care is where we find stigma at its most dangerous. Substance use behaviors are linked symbolically to a range of other stigmatized health conditions. These negative stereotypes guide social action, public policy, and the allocation of healthcare expenditures. So when we say that stigma is the biggest barrier to ending the opioid epidemic, this is how pervasive it is. It is through all the systems. It comes in how are we going to spend the money, how much money are we going to spend, how are we going to utilize the money, down to that moment when a patient walks into the ER and says, I need help. So it's just so embedded. Contributes to poor care. Health professionals may have an avoidant approach to delivery of care with substance use disorder patients. We've seen it many, many times. The most recent times that I've been over to the ER to check on some of my patients, I have encountered painful, stigmatizing my patients. Very direct, stigmatizing language directed at them. Expression of less empathy. Oh, slide, thank you. All right. So what to do about stigma? Education, personal witness, shift language and terminology. Next. So stigma is discrimination. So when we encounter discrimination, we have to seek justice. Justice in every aspect of substance use care requires persistent advocacy. We really have to get out there and push hard against the systems to make changes, to allow changes, to fund changes, calling for fair policies and laws, true insurance parity, education throughout healthcare, schools, and community organizations. This is how we turn the tide with a stigmatized disease where many people are dying. Because of the slow response to the opioid epidemic, our people have spiraled further. As a nurse case manager with my own caseload of medication-assisted treatment in Chapaday, my case management struggles are a nightmare. Getting people into the right level of care, setting the support they need, getting family support. Every single patient, I am quilting together a little blanket of care because agencies mostly are both overwhelmed and really underfunded. So justice is about adequate funding for effective evidence-based care and resources to establish whole person wellness. Whole person wellness, that's the goal. Next. So this is the Recovery Bill of Rights. I know it's hard to read, but you can find it on the website given. Basically, this says we have the right to all the information. We have a right to choices. We have a right to respect and dignity. And so basically, I heard Dr. Waller talking about his patients. We partner with our patients. There's so much paternalism in medicine, so much paternalism in substance use care, where we can't establish that mutually respectful, trusting relationship where choices and information are freely given. Here's what we have. Here's your choices. That is the way to treat someone who has a substance use problem and is seeking help. Next. Next. My favorite pictures. Wait. Out of order. Okay. So the stigma, this is a text I got from a patient last week that I worked with about 10 years ago when I was working at the VA. He sent me this. The stigma is the main reason we don't continue treatment indefinitely. When we are seen as bad, we want to get good as fast as we can. When the job is done, we want to distance ourselves from things and places that make us look like bad people. We can be seen as sick and brave. In fighting a terrible and fatal illness, our numbers would be so much better. That's direct from a patient who has fought hard. Next. Self-stigma, internalized shame and self-condemnation, internalized hopelessness. This is our real enemy, is that hopelessness. The most deadly aspect of stigma is that I cannot get better, I cannot get help, and nobody cares. We have to change that. Street language is, these are the common street terms. Subs stands for Suboxone. That's what people call them, my subs. Got to get my subs. And black refers to the black tar. Medical, behavioral health staff, substance use counselors can be inclined to use street language to be more approachable to persons with substance use disorders. It's important to use dignifying language. This is a pretty common thing that we're shifting away from, where we're okay with our patients saying whatever they say, but we are now in behavioral health, we're now in medicine, we are professional people with care. We don't need to use the street language. Next. Social stigma within the rooms. Talking about the 12-step peer support groups. I am personally a recovering person. I have grown up in the 12-step rooms, but I'm very aware of the stigmatizing behaviors in the culture, not in the program. I've lost many people who went into the rooms for help and got persecuted for being on Suboxone. I lost 3 young vets, 3 young Iraq war vets in 2 months because they were talked out of taking their buprenorphine by their sponsors. It was back in 2014, so I had some skin in the game. So we have to change, as an old timer, I have to make the rooms bigger. We have to make the rooms bigger because there's such good support information in the 12, so we can't toss it out. We have to make it a safe place for everybody. From the 12 traditions of Narcotics Anonymous, Narcotics Anonymous has no opinion on outside issues, and CNA name ought never be drawn into public controversy. That's tradition 10. And what that's saying is what a person is prescribed by their doctor is an outside opinion. It's important to remember that. So it's practicing medicine through the culture. It happens in a way that is kind of pernicious, but it's important that we change it. So if anyone here is part of the 12-step world, it's on us to make the change, to save lives. Stigma within families. The same around substance use disorders often starts in childhood with parents with alcohol or drug problems. This leads to early isolation and exclusion and internalized shame. Any one of us that has grown up in alcoholic or drug-using families understand that there are times when you absolutely cannot bring a friend home because of what might be waiting there. If there's an adult user in the household, we already, as children, are starting to feel the stigma of addiction. And because of shame, families tend to struggle in secret. And we know we're only as sick as our secrets. Strong parental resistance has been the reason patients decline buprenorphine and methadone treatment because of their views often informed by internet conversations, community prejudice, and the fear of a new dependency. I encounter this a lot. I'll have a patient come in, they're ready to start our buprenorphine program, but their parents do not want them to go there. So the solution is, I say, would you mind bringing a parent in, and we do some education that usually helps quite a bit. Next slide. Stigma within communities. That's more addressed by Albert, but Native culture and tradition, recovery care in Native communities is usually 12-step informed, where buprenorphine and methadone treatment is considered still using. Not accepting of those receiving MAT care. I've seen this. I work in an Indian health clinic. Excluded from ceremonies and sweat lodge where complete abstinence is required, and understandably suspicious of mainstream medical treatments, especially after the harm coming from long-term opioid therapy for chronic pain. So when we go, okay, we blew it with the pain pills, and we have this new med. So that suspicion is pretty common and pretty justified. Church and religious cultures, substance use disorders have long been viewed as a sin, and returning to worship is a strong sign of recovery. Stigma stops people from seeking treatment because of the fear that they will not be treated with respect or dignity within the treatment system. Powerful and pervasive stigma prevents people from acknowledging the problem, much less disclosing it to others. When you think about it, next slide, when you think about how Alcoholics Anonymous started in 1935, the whole premise is we have to be anonymous. No one can know that we have a problem. So we got a ways to go. It's really interesting to see that. Stigma deters the public from wanting to pay for treatment, reducing access to resources and opportunities for treatment and social services. This epidemic had to get mighty big before we saw the money. Stops people from seeking help. That is one of the big effects. Structural and institutional stigma. What does that look like? EDs and county jails have been the default detox settings. There's so much change happening in this environment. Persons with opiate use disorder, these settings provide a unique and important opportunity to destigmatize the care. You guys are doing it, you're on the front lines. The California Bridge program has taken a powerful lead. North Indiana Hospital has received a grant. You guys are running with it. Very beautiful. Changing the culture in the ED is one of the most powerful things a community can do, because that's where we go when we're in most trouble. A MAT program patient recently shared about Suboxone in the local NA meeting, and someone in the group suggested that they no longer share. It's one of my patients, because they are on Suboxone and not clean. So we have work to do. So that's institutional. Discussion of tapering off of buprenorphine with providers and counselors is often couched in the context of not being viewed as abstinent, or in the context the patient is using a crutch. It's getting better, but over the years it was like, when are you going to come off it? As soon as you were getting started on buprenorphine, the next question is, when are we going to taper you off? Research has really supported at least 2 years of, maintenance. And the language in medicine is changing quite a bit around this. So, but still, I have patients that will be seeing a substance use counselor that's talking about when they need to get off of it. Institutional stigma, the justice system. Over the years, it's taken the judges some years to recognize the importance of evidence-based care. For many years, when patients were ordered, keeping up with me, keep forgetting. Patients were ordered into treatment. These were my patients. Many, many times, the judge would tell them to come off of buprenorphine or not to start it. You can go into rehab, get out of jail, but you can't be on buprenorphine. Very, very common. Law enforcement, so beautiful to see law enforcement in this room. Thank you so much. Powerfully impacted and overwhelmed by overdoses and crime. Local police departments, county sheriffs need support and education. Grass Valley Police Department, where I live, they have what they call a dignity bed. In one of our local treatment facilities, they got a grant so that they have a bed 365 days a year, so they pick somebody up. But the best option would be for that person to go directly into treatment. There's a bed there. Somebody's not taking it. But that's a big step. That was when the partnering really began to happen. Our MAT patients are now continued at the local county jail. They show up and they say, I'm in the Chapaday MAT program. The doc will give me a call, go, what's their dose, and they are continued while in jail. Next. Next slide. So that's the Betty Ford Center. That's where I first learned about how to be an addictions nurse. Betty Ford Center was a rigidly 12-step informed setting. We used buprenorphine. We were one of the first people in the country, one of the first agencies to use buprenorphine. We used it the day after it was FDA approved, but a patient could be on it for 2 weeks or less. We used it as a detox agent. The message coming out of Betty Ford was always, we want abstinence, we don't like maintenance, and it was just in recent years that they made the shift. So one of the places that have been most resistant, that are real vectors of stigma, are the residential treatment centers. I have placed people in residential treatment for many, many, many years after I left Betty Ford. And the door to treatment with buprenorphine was slammed shut. Residential and outpatient treatment facilities, using the dirty, clean language for lab results is still universal. Cultural change can take time. So that was the Minnesota model. Complete abstinence. 12 to 14% works for 12 to 14% of people with substance use disorders. Next. So the recovery settings have been closed. I lived close to a provider of residential treatment last, let's say 18 months ago. If I sent a patient over there, they would say, well, we're going to have to take them off of their buprenorphine. Now they have been given a huge chunk of money, and they're the biggest providers of MAT. That's in 18 months. They went from no to get in here, we're going to help you. So it's been a big, rapid shift. The state of California will not fund beds through the Drug Medi-Cal organized delivery system of care unless buprenorphine is accepted and staff is trained. Next slide. So, this is a structural, institutional form of stigma in in my humble opinion. So this is a routine primary screen that we use in primary care to assess for alcohol and drug use. Anybody here know about the CAGE? Common, validated tool. So the questions are, have you ever felt you ought to cut down on your drinking or drug use? People annoyed you by criticizing your drinking or drug use. Have you ever felt bad or guilty about your drinking or drug use? Have you ever had a drink or used drugs first thing in the morning to steady your nerves to get rid of a hangover? Well, I find this to be, this was developed in 1968, a very long time ago. I find this to be disrespectful and intrusive. I think the term eye-opener is actually a street term that people with alcoholism have used, to manage their morning withdrawal, also known as a hangover. Asking somebody in a primary care setting if they feel guilty or annoyed, I don't like this. And I have never used this. And if I'm in a setting where they want to use this, I push back. We need to use really respectful screening. And there's a lot of conversation going on about how do we respectfully screen our substance users. So just wanted to throw this out here. Next. Stigmatizing language no longer used. We got rid of the word abuse. Substance abuse is everywhere. The substance abuse mental health services, federal thing, they're everywhere. SA means substance abuse. Was identified as the only diagnosis which had the word abuse in it. Abuse, misuse, substance use. Addict. What would it be like if we stopped using that word addict? That's a big step. What if we said opioid users, methamphetamine users, alcohol use disorder, alcohol users? Calling somebody an addict. I don't know if any of you have sat with a person and you're talking about their pain management, maybe their medication protocol, and they go, I'm being talked to like a drug addict. And I've heard this countless times. And people who have addiction, who have opioid use disorder, are, fully into the behaviors of addiction. Calling somebody an addict, I don't think is necessary. So I'm going to encourage everybody in this room to think about maybe not using it. People who use drugs, people who inject drugs, opioid users, person first. Persons who. Drug seeking can be reframed as relief seeking. All of us in medicine have used this for many, many years. Drug seeking, somebody walks into the ER and they're identified as a drug seeker. We withdraw our care. But if someone is coming in, they're in withdrawal or they're having craving, a better question is, what kind of relief is this person seeking? Focus on the person rather than the behavior. Nodding out, I heard this term in my own clinic a few months ago. Someone who was associated with one of my patients was described by the front desk as being out in the waiting room, nodding out. The assumption was that this person was under the influence of drugs. There was no other evidence except that they were a little sleepy. So I really feel like it's important that those kind of comments don't happen in our clinics. Next slide. So language matters. This is just a little picture of former addict, person in long-term recovery, person with a substance use disorder. Clean is actually a term that the other side of it is dirty, so we're going to get rid of that. Not actively using, substance use disorder. Some places are replacing relapse with recurrence. So Sometimes I say they resumed use. Urine drug screens. In medicine, we do not refer to lab results as clean or dirty. We use medical language at all times to support the dignity of our patients. This is the most common and most stigmatizing term that goes on in our clinics. We say consistent or inconsistent, appropriate or inappropriate, depending on the purpose of the drug screen, the lab result. We say positive. We need to be specific. Drug screen is positive for opioids, positive for methamphetamines, for example. This is one great big change that we can all make in medicine and in all the walls of care. Next slide. Stigma is a secondary injury. Substance use can require care. So over the years, I've been sitting with my patients and really having conversations about stigma, how it impacts their lives, their choices, their fears. And I've begun to see that they have acquired secondary injury. It's almost like they come in with a really bad rash, just from the stigma that has been directed at them over the years. Next slide, please. I began to look at this as something that needed treatment. The stigma injury, how to heal, how to treat. You begin with the acknowledgement of the injury caused by stigma. Symptoms can be fear of not this one, emergency departments. In my town, it's terror of the ER. Distrust of medical providers, big deal, that's a very big one. Feelings of shame and dishonesty. If not treated, the person internalizes. So the treating is offering doses of dignity, empathy, leaning in, compassion, kindness, respect. Dr. Gashgarian, listening, who's treating the stigma directly. Very, very powerful. So generous doses, you cannot give too much of that. Sometimes providers will go while you're asking us to be nice to them or enable them. Sometimes kindness is perceived as enabling. I think we need to explore that a little bit. Sometimes we need to do interventions on behavior, the choices that our patients are making that does not require us to be less kind. Next slide. How to treat. Openly and directly acknowledge to the person that stigma has contributed to their suffering. Humility exhibited by medical providers and care teams is a balm for the stigma injured. Our understanding that we can do better and our communicating that is really a gift that we can give to our patients. Develop trauma-informed care. We've discussed this, Albert, at his presentation on trauma-informed care. Dr. Waller's discussion of how it builds up in the brain, and that stigma is traumatizing for people seeking help. Part of the stigma now is that part of the trauma is that they have been stigmatized. For some, it has been decades of disrespect, harsh judgments, and minimal care. Think about that. Decades of disrespect, harsh judgment, minimal care. Stay focused on the human being and bring respectful, compassionate interventions to the addictive behavior and to destructive choices. Partner with our patients, develop proper choices and options throughout the care visits. Keep the doors open to care in the face of relapse. This door will always be open to you. This is one of the first things I say to my patients when they come in. I'm so glad you made it in. No matter what happens, this door will always be open. Because sometimes our patients leave, resume use, spiral, and they pick up that phone 6 months later. trauma-informed care is essential with opioid use disorder. If you're looking at heroin, you're looking at trauma. Needle use is a form of cutting. It's a behavior. Lots of education, support, level of care. You have to really find out where this patient is going to do best. Per the American Society of Addiction Medicine criteria, case management, tons and tons and tons of case management is required. Referrals based on level of care, outside providers, clear expectations, phases of care, refill and stabilization groups. That's something I've been doing for a long time, is having groups where patients come in once a week. Next slide. The solution, recovery and wellness, culture and tradition. White Bison, the Red Road, we have a Red Road talking circle in our clinic. Restoration of wellness, it's whole person understanding the impact of historical trauma. 12-step support, healers and artists. People with addictions tend to be very sensitive. That's one of the reasons that we use and drink. We feel things. And that healing process for someone who is using drugs or alcohol is discovering our ability to carry our gifts to the world as healers, as we're good healers, and also our creative possibilities. So when I'm with my patients, I don't just see a bunch of people recovering from their addiction. I see healers and artists. And it's really a joyful process for a lot of our folks. Culture and identity, very important. Behavioral health, life directions. A lot of my patients need help getting a job, getting the basic things. I had a little fundraiser last year for one of my patients so she could have a car. She had a child. Her life took off with that car. Boom. Got a job, could take her son to school. It was a little thing. It was a little thing that continues to serve them. And restoring of relationships. Big part of the whole person wellness is getting our kids back, our families back, respect back with all of our relationships. Next slide. The solution, access to care, addiction treatment starts here, wherever we stand. Develop a medication-assisted treatment program, which we're doing, community outreach and education. This is a vital community in that area. No wrong door, have an effective referral system, and evaluate all barriers and adjust for improved access. That's the solution. So this is, next slide, this picture is a picture of the state capitol in the great state of Vermont. My home state, they got hit hard by heroin and had to fight hard. Developed the hub and spoke program, which is a model that is used in California. Never mind that the state of Vermont you can put it in Inyo County, so it's pretty small. But policy recommendations for addressing stigma and discrimination. So we have to really support good, non-stigmatizing policies. Meaningful insurance coverage, enforce public and private insurance, consumer protection, support education and outreach, treat justice-involved individuals, promote treatment, recovery while incarcerated. These things are all beginning to happen, but this is new. Most places in California, this is within the last 12 months. So, next slide. Another pretty state capital. So, addict, junkie, druggie, liar, failure, criminal choice. How about human? Stay close to that human being and who they are as a human being. We're going to make progress. Next slide. Stigmatizing is ongoing work. Ourselves, our families, our communities, our cultures, our programs of care, our agencies, our institutions, and our laws. We don't need to correct each other. We can just correct ourselves. Oops, I said dirty. be the change you wish to see in the world. We model it to each other. This is hard work. The front lines are still very thin with the epidemic. And we have to really help each other and do our very best. There is an addiction stigma handout, Dr. John Bachman, so here's some of the things that you can access. And that's all I've got. Any questions? Any arguments? Oh, no. Never. But the program of the 12 steps and 12 traditions do not have a policy about medications, is my point. It is an outside. When I got into AA in 1986, I'm self-disclosing, in 88, Prozac came out. And there were people in the rooms that were going, my life is so much better. I am getting it. And there were old timers in the room that said, if you're on Prozac, you're not sober. And at that point, I wasn't a nurse, but I was like, that can't be right. And then I watched a friend who had severe bipolar 2 get told to come off of all the psych meds, and he died after 12 years of sobriety because coming off of all of his meds was really not good advice. So my point is the culture needs to really reinforce the traditions that are in place and the steps are in place. So no, I do not want to rewrite the 12 steps. I want to make them more powerful in the culture. The rooms are bigger. Does that make sense? Yeah. Okay. She's talking about how to use urine drug screens in a way in a medical setting that reinforces their care without it being more like law enforcement. Those are our patients that have drug screens about probation or about staying in treatment because we've been sick, they've been sent there. So the tone, and that's a very, that's a subtle tone. If somebody is prescribing buprenorphine, there are safety issues. And so it's all about safety. All about safety. So we need the drug screening to know that you're not taking it or you're not taking something else that may be dangerous. The provider, the prescriber needs to know, and it's always in the context of safety. That's how we do it. And we do it a lot. We want to know everybody's doing well, so. Sometimes I'll say, come on in, we don't care what's in the urine drug screen, just come on in, we want to see you. Any other questions? Any arguments? Okay. Thank you for your time, everyone.